I'm Nick Evans. I'm a researcher within stroke medicine and a consultant here at Addenbrooks. And it's a pleasure to be speaking to you all about some of our research, but I'm also keen as well to talk about research more generally in the east of England. And I've put this title as sort of research in the past, present, and future, because actually we are facing a demographic time bomb. We face an increasingly older population within the east of England. And what I will be talking about is about how we tailor research to look towards this change in demographics, and also as well about sort of my group's research into how blood vessels age, how that affects the brain, and then how that relates then to the individual. I'm very happy to field any questions as we go. I can't see the chat function, but please call out if there's anything. Otherwise, I'm happy to talk about it at the end. But I think it's important that we put all of this in context. So in the course of the hour for which we'll be meeting, the 12 people in the UK will have a stroke. That's one stroke every 5 minutes. That figure by this time tomorrow will have risen to around 300. And if I was doing this on the 17th of June in 2026, in 1 year's time, that figure will have risen to around 110,000 strokes. It's one of the leading causes of adult disability in the UK and affects not only the individual, but their families, their carers, but also as well the healthcare and the economy of the UK as a whole. It costs around, at the moment, around sort of an estimated £26 billion per annum when you factor in the loss of earnings, the loss of family earnings, direct healthcare costs from stroke per annum. So the scale of the problem that we face is vast. Now, we hear a lot sort of in the media about managing vascular risk factors. And of course, that is very important. And certainly at an individual level, it's very important for trying to reduce somebody's risk of stroke as much as possible. But we do face a rising number of strokes in the course of the coming decades. So here is a fairly recent paper that's looking at the number of both ischemic strokes, hemorrhagic strokes, and remember, about four out of five strokes are ischemic. That's when you have a blockage of the blood vessel, meaning that there's not enough blood supply going to the brain. Hemorrhagic is when you get a bleed on the brain. We can see that actually there are rising numbers as we go. We're now in 2025. But in the projected next 10 years, you can see that the numbers of ischemic strokes and hemorrhagic strokes, and therefore the total number of strokes, is expected to rise. And as I said, although we are getting better at detecting and managing people's risk factors, that is partly a reflection of the fact that the population is getting older, and age is a risk factor for stroke, and is one where actually it is very hard to combat the number of times somebody has been around the sun in terms of their chronological age. And one of the take-home points I'm going to raise today is the importance of differentiating between somebody's chronological age and their biological age. And I will come back to that throughout the talk. But there is good news, is that if one looks over the course of the time since the sort of 1970s, we can see that the death rates have fallen. I was a medical student 20 years ago, and I remember that if somebody came in with a large stroke at that time, very often they were either left severely disabled or sadly they died. Now we are seeing, with our advent of hyperacute stroke treatments of thrombolysis, that's clot busting medication, and mechanical thrombectomy, that's a procedure that we do to remove a clot within the blood vessels. We now have individuals that previously would have been left severely disabled who are potentially walking out of hospital after a few days with very little to no symptoms. So there's been a game changer within the course, certainly of the last 20 years. And we see here that the death rates from stroke have fallen. But as many of you will now start to be thinking, well, if the number of strokes is going up, but the death rates there are falling, that obviously means that there are more individuals who are living with stroke and potentially living with the after effects of stroke, which means it's really important that we are looking about how best we support these individuals. And a major part of that then is how we are tailoring research to support and improve the care for these individuals. But all of this then costs money. I've already sort of alluded to this, and I've mentioned about sort of the overall costs. These are figures in millions, but really just to kind of re-emphasize here that actually this is a big priority then for the health service and the UK economy as a whole. But of course, numbers tell only part of the story, and many of us on the call will have personal experience with individuals who have had stroke, and I'm no exception. The sort of young, sort of chubby chap on the right-hand side of the screen there is me. That was a photo taken of me with my grandmother, and that photo was taken then just over 10 years before my grandmother had a stroke. And one could see then the effect of a large stroke affecting somebody's movement, about their speech, about their quality of life, and the impact that it has not only on the individual, but their families as well. And as I said, is that a lot of the interventions now that we have that are being delivered in 2025 were simply not available then when this happened in the 1990s. And so, but there is still plenty of work to do, and I'm going to discuss that then today. And I'd value your thoughts on how we sort of improve and deliver this research. So what has happened then? I've already alluded to how things have moved on quite quickly, kind of relative to a lot of other specialties, about how things have developed quite quickly in the sort of last few decades. So actually, it was only really in the 1990s that sort of clear evidence emerged that having a dedicated stroke unit within the hospital improved the outcomes for people. Now, sort of prior to that, then very often, and indeed actually for large chunks still of the 90s, is that if somebody had a stroke, they were often looked after on general medicine wards. Now, that's not to be derogatory to my general medicine colleagues, but what we have seen is that having a dedicated group and multidisciplinary group of stroke doctors, nurses, physiotherapists, occupational therapists, speech and language therapists, dietitians, there are many people that are involved in helping somebody recover from their stroke. And what we have seen is having a dedicated unit where all of those individuals are found in the same place there has a beneficial effect for stroke survivors. My field, looking at sort of vascular aging and vascular disease, it was in the 1990s, so sort of around sort of 30 years ago now, that there was emerging evidence that if somebody has significant furring up of the arteries, that's atherosclerosis, that's a major risk factor for stroke, and that doing an operation called a carotid endarterectomy, where the artery is opened up, that narrowing is scooped out and removed, that was then shown to be superior then to treating this furring up then with tablets. In the late 90s into the 2000s, then this is when we started then looking at clot busting medication, thrombolysis, as I've already mentioned, where if somebody is having an ischemic stroke where a blood clot is blocking the blood vessel, we use medication then to try and dissolve that clot. In the 2010s, we moved on from warfarin then for individuals who have atrial fibrillation, an irregular heartbeat, which predisposes to clots forming within the heart that can travel up into the brain to cause a stroke. And we moved on then from giving warfarin to then much more effective agents that also do not require the level of intensity of monitoring that warfarin did, and have been shown to be more effective at reducing somebody's stroke risk. And as I've already alluded to, in 2015, so 10 years ago now, was when we first started seeing strong evidence that mechanical thrombectomy, that clot retrieval procedure that I've already mentioned, then has a very powerful effect on being able to reverse the effects of stroke. And pretty much then for every sort of 2 to 3 individuals that we treat with thrombectomy, one of those individuals will experience an improvement in their symptoms. And around for every 4 or 5 people that we treat, then they will pretty much go back to how they were before the stroke. So it's a very powerful intervention. So just before I move on to my areas of research, I just want to then look at where are we within the east of England? What are we doing across the region? So I think it's important that we highlight that research is being done across the whole of the stroke pathway. And from that, I consider that from the moment that somebody has a stroke, typically in their own home, from then about recognizing stroke, and about the work then being done to improve the pre-hospital care, to then the hyperacute care that an individual receives when they arrive in the emergency department, to the acute care that they have in the first few days on the stroke unit, to then the rehabilitation to helping them recover after the stroke. So just looking at these, one of the things that we are working on within the East of England is how can we improve the detection of a stroke? Now, I've already shown the FAST slide, the idea that we can sort of better recognize strokes by thinking of face, arm, speech, and time to recognize a stroke, and about how timely stroke treatment there is key. But actually, how can we better then differentiate between somebody who is having a stroke and another medical condition that can mimic the effects of a stroke, to make sure that these individuals are getting the right treatment at the right time in the right place? And there are increasing number of studies that are looking at being able to do sort of what we call point of care blood tests, so sort of finger stick blood tests there that might be able to look for evidence that somebody is having a stroke or a particular type of stroke, which means that they need to come to a thrombectomy centre such as Addenbrooke's to be able to make sure that they have this procedure. And also as well that there's increasing work looking at sort of mobile stroke units, ambulances that have CT scanners, small CT scanners in the back that enable us then to do some imaging before an individual arrives in the hospital. In terms of hyperacute care, when somebody arrives, we're looking at developing how we improve then the clot busting treatment, about how we better understand about how different individuals, such as individuals at different ages or different physiological age, respond to these different treatments. But also as well, I've talked a lot about ischemic stroke, also as well about how do we better treat individuals presenting with hemorrhagic strokes, those 1 in 5 strokes there who present with bleeding on the brain. And then after an acute stroke, then improving our treatments to decide when should we start or restart particular treatments. How can we treat then some of the effects of stroke, such as inflammation within the brain that can have a complex interplay in terms of somebody's rehabilitation? And how can we then improve some of the treatments for a major cause of stroke, this furring up of the arteries in the carotid arteries? That's the main blood supply going up to the brain. And then finally, then about rehabilitation, about improving aphasia therapy, about tackling the after effects from stroke of fatigue and apathy that are sort of kind of neurological consequences of stroke, and also physiotherapy and occupational therapy interventions for individuals, including potentially delivering rehabilitation for somebody, once outside of hospital, such as being in their own home. So I'm really going to highlight these 2 areas that are my areas about the treatment of carotid disease, and also as well about treatments then when somebody arrives in the emergency department. So I've touched on this several times. Carotid atherosclerosis is a major cause of stroke, probably underlies somewhere of around sort of 1 in 5 to 1 in 3 causes of, or 1 in 3 ischemic strokes, depending on where you live in the country and depending on sort of various people's sort of backgrounds. And there's been this sort of kind of conventional view that the atherosclerotic plaque is largely like limescale building up within a pipe. Now, that what we have come to understand over the last few decades is that's a very simplistic and a very reductive view of it. And actually, rather than it simply just limiting flow, what can happen is that furring up there can become damaged and inflamed, the same way that if you sort of bang your toe or your thumb, it becomes red and angry and swollen. So too can this furring up then develop, particularly in response to the vascular risk factors that many of us are familiar with, of diabetes, high blood pressure, smoking, or high cholesterol. Now, as I'm going to come back to, the difficulty is that a lot of our scans only show how narrow the artery is. They don't give us an idea of what is going on sort of metabolically within that furring up and reflecting that risk. So just to re-emphasize this point is that let's think about how atherosclerosis develops. Now, one starts off with a normal blood vessel, but in response to these vascular risk factors that I've mentioned, this furring up starts to develop. And that furring up then is deposits of cholesterol. But what you also end up getting is lots of immune cells, particularly macrophages, that get infiltrated then into the furring up. So that's the kind of underlying cause of the inflammation. Now, as that then atherosclerosis then starts to develop, over time, what we typically see is that actually the furring up then starts to harden. It becomes calcified. The same process by which sort of we form bone actually occurs within our blood vessels, particularly as we get older. And the rationale is that pretty much as that plaque then develops, if it then starts to become calcified, is that it's sort of meant to stabilize the plaque. But there is a key transition point here where with the combination of inflammation and calcification, it can cause damage to the lining of the atherosclerotic plaque. It causes then blood clots to form on the surface of the furring up of the artery. And as I've said, the carotid artery is the main blood supply going up to the brain. It's the one you feel when you feel the pulse in your neck. That clot then subsequently travels up into the brain to cause an ischemic stroke. And this complex interrelationship between inflammation and calcification becomes a vicious circle. We know that the more inflammation that there is, it causes then deposits of calcium. These very small deposits of calcium called microcalcification, which are tiny. For those of you who are inclined in this way, they're less than 50 microns in diameter. So it's something that we can't see using our conventional imaging technique. But what happens is the inflammation drives that small deposits of calcium that destabilize then the top of that atherosclerotic plaque. And then you get this combination of inflammation causing damage and the mechanical damage then from these small deposits of calcium that disrupt the architecture of the plaque. And it's these complex interactions then that cause the plaque then to become unstable, to rupture, clots to form, and the stroke to occur. But as I said, the trouble is we can't, using our conventional imaging of ultrasound, as you see on the top scan on the right there, or CT scanning, which is shown on the bottom square on the right-hand side there, they largely just tell us about the degree of narrowing within the artery. They don't tell us about these physiological, these kind of pathological processes that are going on within the arteries. They don't tell us metabolically what's happening there. And that's where our research comes in. So we are using a specialist scan called positron emission tomography. It is a scan that is used routinely within cancer care and also as well certain sort of other conditions. But what it enables us to do is with the use of injectable tracers, it enables us then to target particular metabolic processes of interest that allow us then to be able to detect it, to be able to quantify it as well, to measure it within the body. And what I'm going to be talking about is then how then these tracers have shown what is going on within these plaques, within these atherosclerotic plaques of the furring up in the arteries, and how that relates then to somebody's sort of aging, the changes in their brain. So this scan we have available in Addenbrooke's. The scan overall takes about 20 minutes or so. So I'm going to talk about the first tracer that we're talking about, which is looking at these small deposits of calcium that we can't detect using other imaging techniques. And that tracer is called sodium fluoride, otherwise known as NAF. And that gets taken up into these areas of microcalcification. And this is a sort of scan here that we are able to see. So here is an individual who has had a stroke. And in this instance there, they have got disease in their right carotid artery. You can see there their chin. That's the area that I'm just going to see if I can pull up the marker. So you can see this green area here, which is disease within the carotid artery, and that's uptake of the sodium fluoride. Here's somebody's then otherwise normal left carotid artery. And what we can then see is by doing this scan, we are able then to identify where these areas of microcalcification are occurring within the body, and also as well to be able to quantify them. Now, the detection is important. Being able to decide whether or not a plaque is at high risk of rupturing and cause a stroke is important for determining what we do about it and detecting it and being able to treat it aggressively. But also as well is that it also has got relevance then for what is the likelihood of somebody going on to have a second stroke. And when we speak to stroke survivors, that is very often one of the key questions that somebody has is, what's my risk of further stroke? And what we have found is that for individuals where the uptake of the sodium fluoride signal is higher, suggesting that there's a much higher burden of microcalcification, these individuals then are at a higher risk of having a further stroke within the subsequent 6 months. This is an individual there who has not had a recurrence, and that's the uptake measure you can see here. But for those individuals who have had recurrence, one can see here that there's a much higher uptake of the sodium fluoride signal. So from that, we're able to detect high-risk plaques. We're able to better risk stratify these plaques and about somebody's risk of further stroke. But as I've already shown, is that microcalcification is only part of the story. We also know as well that inflammation is the key process here within the lining of the blood vessels. And again, we are able to detect that yet then using PET scanning, using a tracer called fluorodeoxyglucose, or FDG. That FDG is basically a tracer analog. It's like a radioactive sugar and gets taken up at high areas then of metabolic activity, such as where there is inflammation. And this is what we end up seeing. So this is an individual's then inflamed carotid artery. They've got atherosclerosis there. And we can see that when you've got this furring up in the artery, the carotid artery, the course of it is shown by the white arrows there. It becomes inflamed along its entire course. So we see that individuals with atherosclerosis, it's not just about the point where the narrowing is, but actually the whole of their sort of blood vessels then throughout their body becomes inflamed. So as one can then start to imagine, if you've got a high burden of inflammation throughout the entire body, that is going to have an effect on a lot of organs. We know that organs respond to generalized inflammation in a variety of different ways. But as a stroke physician, one of the areas I'm particularly interested in is what's the downstream effect of inflammation on somebody's brain, aside from them having had a stroke. So here are the scans from two different individuals, and I'll talk you through it. But one of the sort of major sort of roles of brain aging and of sort of kind of brain health is to do with these kind of chronic changes deep within the brain, what we call small vessel disease. Now, I'm actually going to point out the scan that you see on the right-hand side here. This is an individual here who has sort of more severe small vessel disease. You can see around these ventricles within somebody's brain, you can see this kind of white area, this kind of cloudy appearance here, which typically tends to develop as we get older, but particularly in response to vascular risk factors like high blood pressure. Now, these are important because we know that the development of small vessel disease here increases somebody's risk of a wide variety of downstream clinical symptoms, such as effects on somebody's cognition, effects on things like walking, about their gait, about continence, about mood disorders, and also movement disorders such as things like vascular Parkinsonism disease. So it has a very sort of actually sort of profound effect on a range of different symptoms. In contrast, for somebody then who has a kind of younger brain in inverted commas, but one where there is less severe small vessel disease, you can appreciate here is that there's little of this kind of cloudy appearance going on around the edge of their ventricles. So from my perspective, looking at the scan, the one that we see here on the right-hand side is one that I would consider a much more vulnerable brain for developing complications than the one that you see on the left-hand side. So the question in my mind and as part of our research was, how does then inflammation within people's blood vessels affect then the downstream effect on somebody's brain and the development then of this small vessel disease? So what we found is that for individuals that have sort of minimal small vessel disease, otherwise known as leukoariosis, yes, we saw that there was some inflammation. This is at the bottom here, sort of the FDG scan looking at inflammation. And yes, there's a little bit of uptake in the carotid arteries that you see highlighted here and also as well by the green arrows. But when we then saw somebody then that has more severe small vessel disease or leukoariosis, hopefully, as you can appreciate here, is we are seeing that their carotid arteries here look red hot. there is much more inflammation going on. And unsurprisingly, that inflammation there appears to have a downstream effect on the development of this sort of background effects of brain, effects on the brain in terms of this small vessel disease. And we know that that small vessel disease has these profound effects that very often get sort of kind of considered as part of aging, but actually may well reflect actually these changes within the brain. Now, this sort of idea then of sort of inflammation and microcalcification within the blood vessels then, and also then the downstream effect on the brain, opens up potentially exciting opportunities to improve our treatment of that inflammation. Now, there are, of course, a number of new drugs that we are trying that are sort of anti-inflammatory medications, but also we are using we are doing a lot of drug repurposing that are existing drugs that are used to treat other conditions that may have some degree of anti-inflammatory effect. That means that these drugs are already in clinical practice. We know their safety profile. We know that they're already in use and typically well tolerated. Rather than necessarily sort of having to go down the route of a completely new drug, what we are doing is trying to avoid reinventing the wheel and using drugs that we have used potentially for decades, but with a new purpose to be able to kind of use their anti-inflammatory action then to be able to treat the inflammation within the arteries and hopefully as well reduce that drive to the effect on what's happening within the brain. So actually, statin medications have an anti-inflammatory effect, and that is one of the major reasons for particularly for people with furring up of the arteries, is ensuring that they are not only reducing their cholesterol levels, but also as well reducing the burden of inflammation. But other drugs that have been tried sort of in the last few years, gout treatments, a medication called colchicine, suggests that it's already been used in terms of stabilizing furring up of the arteries around the heart that can lead to heart attacks. And there is some suggestion that actually this has a benefit then if individuals then have furring up of the arteries going up to the brain. We are doing a medication it's called minocycline, which is an antibiotic that is typically used to treat acne. And the benefits from our perspective are that we know that this drug is typically used for months on end and is very well tolerated typically by individuals who are on it. So what we are currently doing is a study called Minotaur study that is using minocycline, which in rats we have found inhibits and reduces the risk of calcium forming, of that microcalcification forming that would otherwise then increase somebody's risk of further stroke. What we are doing it then is in humans, in individuals who have had strokes due to furring up of their arteries, and seeing if that then helps reduce then that microcalcium activity as measured by the PET scans. Another study that I'm very excited to say has now completed recruitment, and we are waiting for the preliminary results that we should hopefully have before Christmas, is using a medication called sodium valproate that has been used in treating epilepsy and migraines for decades. But what we have found is at a population level within the UK is that if you are on this medication, you seem to be at a reduced risk of developing strokes because of furring up of the arteries. And what we have seen is that sodium valproate appears to reduce particular proteins and particular processes that lead to inflammation within the arteries. And so we have been looking at that again with PET scans to see whether that helps reduce the amount of inflammation that's going on. And then finally, as well, using chemotherapy drugs, which can be used in a range of different settings to reduce some of these processes. So I think, whilst a new drug shows exciting promise and can sometimes be very potent, I think actually it's also important that we don't neglect the drugs that we're currently using in clinical practice, that we might be able to get to the clinical coalface much faster because we're able to repurpose some of these drugs. So I've spoken then about how this furring up of the arteries that occurs typically as we get older, that relates then to sort of vulnerable vessels, the likelihood of clots forming and causing a stroke, can also as well cause these kind of more chronic changes within the brain, this small vessel disease that means it becomes much more vulnerable then to developing disease. But ultimately, as a physician, what I'm most keen to understand is the effect of all of this on the individual that's having the stroke, and what does it mean then for their treatments and their recovery. And that's what I'm going to be talking about in the kind of closing minutes then of my talk. This is important because, as I've already alluded to, is we have a changing age structure within the UK. We can see here that those individuals who are aged sort of 85 or over is roughly going to double sort of in the next 20 years. And as you can see by these sort of demographic charts, we can see that sort of, the numbers here in terms of the numbers of individuals who are at these particular ages is shifting upwards. So it is likely then that sort of as the population changes, we'll see that sort of, by the time we reach the sort of mid 2040s, is that we've got a falling number of younger individuals, of children, similar number of the individuals then who are sort of 65 or above is increasing. And that will pose certain challenges for how we deliver then stroke treatments, because I am very conscious that a lot of the stroke studies have been done typically with individuals who are at a younger age, often somewhere in the region of sort of kind of 40 to late 60s, sometimes into their 70s. But what it doesn't necessarily reflect is actually the bulk of people that we see in clinical practice in the stroke unit. So our average age here at the stroke unit is around early 80s. So I am using evidence that have been done in larger studies, which very often then have older individuals have been excluded from these studies. And I'm very keen that we make sure that we are doing research that reflects the individuals we see coming in through the front door. And that's why I'm going to be talking about some of the work that looks at sort of stroke in individuals as they get older. And I'll sort of kind of talk through a little bit more about that. We also as well move away from thinking just simply of age as a chronological age of just, as I said, the number of times somebody has been around the sun, but also as well to consider actually somebody's physiological age. We can all think of individuals where we think of sort of actually, well, they're much younger than actually their age. So let's talk through with two examples. The individual see on the left here is somebody, a woman called Harriet Thompson, who in her early 90s became one of the oldest half marathon, indeed marathon runners. And I think we can all say here that this, kind of this individual here is behaving much younger than we would expect the sort of average 90-something-year-old individual to be. In contrast, then, I was looking at an individual that was of the same age, and I came across this photo then of the two President Bushes, or Presidents Bush rather, and we can see here that the first President Bush at the same age there, we can see and would suggest also to, just from looking at, looks different in terms of where you would place their age, of their physiological age, even though that chronologically these two individuals are at the same age. And actually, just to kind of flag it up, I think it also as well just highlights the importance of when one makes this assessment, because just by putting somebody in a hospital gown, I think actually probably makes somebody appear much older than they are. It has that sort of kind of physiological, or it has that perception effect then on somebody's physiological age. But the importance I'm raising here is that although these individuals are the same age, is sort of biologically and physiologically, they're behaving very differently. And that introduced then this concept of frailty. Frailty is a scientific term, it is a clinical term that describes somebody's sort of physiological age, and about this state where that somebody loses the ability of their sort of biological systems to be able to maintain all these sort of important biological processes. It means that they are much more vulnerable then to various illnesses. And I'll talk through some examples of that shortly. But we know that individuals who are more frailer, often getting confused with somebody who is older, but actually it's something slightly different. It is their physiological age, is that individuals who are frailer tend to get more sick for longer, and they're less likely to make this full recovery. And it's also as well associated with increased rates of discharge to institutional facilities such as care homes, and also as well increased mortality across a range of different conditions, including, as I'm going to talk about, stroke. Now, this is particularly relevant for all of us living in the east of England, because we can see that actually there's, reflecting the sort of demographics we see in the east of England, is that there is also a reasonably high prevalence of individuals with frailty living within our region. Now, this is important because there is nothing that we can do about tackling chronological age, because simply, you know, as I said, the number of times somebody has been around the sun is not something that we can do about. But actually being able to address somebody's physiology and their frailty may well be something that we are able to do something about. This is just a different way of demonstrating what I've just been talking about. A robust individual, a non-frail individual, as shown in green, starts off with a higher sort of starting point in terms of their level of function. In response to a potentially minor illness in inverted commas, such as a urinary tract infection, we see that there's a reduction then in their function, but actually fairly quickly there's an improvement in their recovery and they go back to how they were prior to this. In contrast, an individual living with frailty typically starts off at a lower level of function, but in response to the same insults, the same medical condition, there's a much more marked drop off in their function, and it takes longer to have that recovery, and their recovery may not be back to where they were beforehand. Now, some of our work that's looking at it has shown that frailty, as measured by you can measure it using something called a clinical frailty scale, is that as an individual becomes more frail, is that we see that the level of inflammation within somebody's blood vessels there starts to increase. And this idea then comes back to the idea of inflammaging, the idea that actually aging and physiological aging in terms of frailty is related then to the amount of inflammation going on within people's body, in particular being driven by the blood vessels. And as you remember, that background inflammation within somebody's blood vessels is also as well having downstream effects on people's brain, and with a number of consequences that are often attributed to as part of aging. But we know that when somebody then has a stroke, it has a marked effect on actually how much damage somebody presents with when they have their stroke. In the top line here, and don't worry too much necessarily about the different scans, but I'm going to talk you through what it's showing, is that for an individual who's non-frail, who is robust, who doesn't have frailty, is that we can see that typically actually the areas of stroke that are affected sort of by this reduction in blood flow, here's somebody's normal hemisphere, but in this instance, the area of brain affected by the stroke is relatively small compared to then an individual who is frailer, even presenting then at the same time, presents with much more extensive damage to the brain, and typically less brain that's able to be salvaged by our treatments such as thrombolysis and thrombectomy. So it's this kind of sort of compound difficulty, is there is less brain to be able to be saved associated with frailty, and probably associated then with that inflammation that goes along with frailty. But also as well, we know that because of that frailty, they are also as well going to have a poorer recovery, probably relating to the fact that the more damage is already more extensive. And we see that. So after we treat somebody with thrombolysis, that clot-busting medication to try and restore blood to the brain, for an individual who is non-frail, we are able to measure the severity of their stroke systems by something called NIHSS. It's the National Institute of Health Stroke Severity Scale. And we can see that if you're non-frail, between presenting with a stroke and having thrombolysis, we can see that there's a clear reduction then in terms of the severity of your stroke. In contrast, if you have frailty alongside your stroke, is that we see that actually there's sort of no significant change then in response to the intervention with our thrombolysis. Now, I want to also flag up here that this is a very crude measure of saying non-frail versus frail. And actually what is very important is that actually there are shades of grey between these extremes. And I think the really key point is that for those individuals who are sort of living on the cusp of starting to become frail, previous studies here would not have included people in studies. They would have been excluded from studies that are investigating then the benefits of stroke thrombolysis and thrombectomy. And actually, from our data that we have seen, is that they continue to have some benefit from these interventions, but it seems to be attenuated because of frailty. So the take-home point is they still continue to have some benefit, but maybe not as much as an individual without frailty. But my concern at the moment is that these individuals then may potentially be excluded from receiving these treatments because of this idea of treatment nihilism, the idea that they are not going to benefit. And I think that is the work that we are doing ongoing to try and figure out a much more nuanced understanding of how frailty, rather than chronological age, but about how your physiological age and frailty relates to your response to having a stroke and your response to these treatments, to ensure that we are not missing people who might potentially benefit, even if it is slightly less so. And that's part of then the study called the Fiesto study. This is a multi-center study that's getting up and running, that is going to run across the UK, but is being sort of driven then by our group here in Cambridge, and is being supported then by the Stroke Association. So just in closing then, I've spoken a lot about, the idea of the vulnerable blood vessel to the vulnerable brain to the vulnerable individual, and the impact that that has in terms of physiological aging and frailty on somebody's effect on stroke. But let's just think about where we stand. I started off by talking about how stroke research and care is being delivered within the East of England. But let's talk a little bit more about how we are going to tackle then the challenge that we are going to be faced with the rising number of strokes and the change in demographics in the East of England. There are challenges, but also as well opportunities to be sort of leading and improving research there, to be able to sort of improve somebody's life after stroke. The challenges that we face within the East of England particularly are we face a large geographical area. Now, if you end up with coming in with a stroke around Cambridge or within Norwich, then actually there are a number of very sort of research, or there are research active centres in the stroke unit then at these big sort of university teaching hospitals. But what about in the smaller hospitals where there is a lot of enthusiasm then for doing research, but there is lacking then the infrastructure or indeed some of the designs of the studies that mean that they can only take place in larger sort of comprehensive stroke centres such as Addenbrooke's and the Norfolk and Norwich. So what we are looking to develop, and indeed Fiesto is looking at, is ensuring that our studies there are being able to be delivered that to a range of different hospitals, and therefore that individuals who have a stroke in Kings Lynn, in Ipswich, Bury St Edmunds, wherever, who are going into the acute stroke centres in the smaller hospitals, have the same opportunity to participate in research and to be able to benefit from research that individuals have if they present then to a sort of university teaching hospital setting. And that's where we are doing some ongoing work about engaging stroke survivors and people affected by stroke throughout the region. We do, within the East of England, have a large population with unmet needs, and that's compounded then by the large geographical areas of some areas of frailty or of socioeconomic deprivation that are particularly prevalent in perhaps some of the more rural areas of the East of England. But I think what's really important, and what we are seeing the change in the last few years in order to develop this, is about the enthusiasm coming from staff and also with participants that are taking part in these research. So it's, really is a sort of a kind of joint enterprise in this regard. We are seeing more studies that are being able to be delivered across the region, and there's an enthusiasm to be able to deliver that. And also as well, working with not just the universities, the NHS and the NIHR, but also as well working with stroke survivors, the public, such as this forum and the forums that we are doing as part of the East of England PPIE initiative, the Aspire network, where we're going out to communities in more rural settings to be able to talk about how we deliver research, and also as well the support then from areas such as charities, in particular the Stroke Association and other local charities. Because as I said, I think this is a really important topic. It's going to be even more important in the coming decades, and also as well for those sort of, let's see, 9 individuals who have had a stroke whilst I've been talking, and for the 12 individuals that have a stroke during the hour, is either being able to help to improve their recovery after a stroke, or better yet, to be able to reduce the risk of them having a stroke at all. So with that, I thank you very much for your attention, and look forward to your comments, questions, and your thoughts on what we've discussed.